everybody. Welcome to the living room. Thank you all for coming. Hello to everyone online. Thank you all for signing in tonight. I'm not sure where people around the globe may be signing in from, but we have been experiencing some unseasonably warm weather here, which makes me really ready for summer and vacation, quite honestly.
Right.
I'm not really sure.
It makes the people on the East Coast very sad.
Yeah, yeah. Tonight, as you guys know, because you all received the emails from Michelle or from Gina or from some sort of communication from the foundation, we have Dr. Dormady coming back. And as most of you who have been with us for a while know, Dr. Dormady's one of our most favorite medical oncologists. He works down at El Camino Hospital in Mountain View. I'm a little tongue-tied right now. He is late. To those of you online who might not have heard me telling the group, he's running a little late tonight, so I'm going to save any big introductions on him for when he comes scurrying in the room. And we're going to do things a little bit differently tonight. I'm going to start with some of the housekeeping and logistics that we usually end this meeting with. We talked a little bit about a two-part series that we're doing here at the foundation. One is a program sponsored by Lilly called The Shared Voice, and the other is a really interesting new concept to us, by no means new to the clinical space, but it's involving continuing medical education. So how do your doctors learn what's happening now in lung cancer, and how are they learning that, and how are they bringing it back into their clinics and incorporating it into treatment plans for some of you? One of the interesting things about this is it's typically reserved for doctors, but what we're doing is we're actually allowing patients and caregivers in the room during this type of presentation, so you can really get a feel for how your physicians are being educated on lung cancer. It's going to be similar to a regularly scheduled living room in that it will be live streamed for those of you online who would like to chime in on it. We have Q&A at the end. So it's going to start with the physician literally giving his presentation.
Or hers.
It's a he.
Oh, okay.
His presentation. And then afterwards, you guys get to ask him questions about how that might relate back to what your care is or is not, and or about how your physician may be learning for you what's coming down the pike. So we're really, really excited and interested in that. And then what's going to happen is afterwards, the film will be sent to Prime Oncology, who's the continuing medical education group that we're working with, and then they will create a web-based CME that we will then push out to lung cancer docs around the country. So that's really exciting. The Shared Voice is going to be on March 9th. All of you should have these or maybe they're not in front of you. There's some on the piano and some right when you checked in. Michelle will also be sending it out to the email list. It explains date and time and what we're doing. Next week is actually the CME event. I have to put my glasses on. And it's actually being hosted at Peninsula TV Studios, which for those of you who may or may not know, is less than a half a mile from here on San Carlos Avenue. So we'll be in their TV studio, hosting it live from there. And then the one on March 9th will be here. So we'll talk a little bit more about that. If anybody has any questions, like I said, you feel free to ask Michelle or I or my mom about what's coming up.
I would just like to add something about the Shared Voice. I was actually in the first Shared Voice video that Lilly did in New York, and the whole purpose is for patients to learn how to talk to their physician. You know, first of all, being diagnosed with any cancer is overwhelming, on that first day, regardless. And you go home and you think, oh, I should have asked this, I should have asked that, I should have asked so many things. So our goal here is to teach you and some of the doctors and physicians how to have a shared voice where you both talk to each other, and the meeting doesn't end until everybody leaves knowing what the plan is, knowing exactly what your treatment program is going to be.
We know that most of you have relationships like that with your docs, or at least hopefully you do, or that decision-making is a shared process. So you're not feeling like you're being told what to do, but you know, being more involved in the overall plan. Right. So it's going to be a great meeting. We've got it'll be here. It's a little different. We've got 2 patients and a caregiver sitting on a panel, and then Dr. Benjamin Levy from Mount Sinai is going to be moderating, and then there'll be Q&A throughout. So there'll be a lot of audience participation. We are asking for RSVPs for that, just because, not because you have to RSVP to come. We're just trying to manage head counts and food and all that kind of stuff, since it's a special occasion. So those are, go ahead.
And there are other patients flying in for this.
Yeah.
Well.
We have some patients from around the country who many of you may or may not know from different internet sites or places where patients connect, whether it's Inspire or Smart Patients or something like that. You may be able to actually meet some of these people that you only know virtually. So that'll be exciting. And some of the folks online who you regularly hear about and who regularly comment on what we're doing here will be coming out for the meeting too. So it'll be nice. It's going to be great. And with that, I think what I want to do is do a little. Katie, I think we're going to do the events after, or do you want to do it now? We can do it now. Okay. We've got time. Katie's going to talk about some exciting upcoming events we have. Yeah.
All right, good evening, everybody. I'm Katie Wilcox. I work on the events team here, and I wanted to share with you guys some upcoming events that we have that if you want to participate in, or you know somebody that is into getting outdoors, going for a walk or a run, that you want to send them this information along, please do so. So I'll start with the 5K series events. We have Tempe, Arizona coming up. That's on February 28th, and I wanted to do a little shout out to Kathy Parker, because I'm sure she's online. Next, we have Gainesville, Florida. That one's on, I don't know if I said it, February 28th. Next, we have Gainesville, Florida, which is taking place on March 5th, and a shout out to Karen Gornberg, who we just visited like 2 weeks ago out in Gainesville. It's going to be an amazing event. Then we have Dallas, Texas, which is our 5K on April 16th, and I wanted to do another shout out to Diane Jordan. And then we're doing a brand new event this year, and it's in Sacramento. So in addition to our San Francisco one, we'll also have a local Sacramento event, and that one's going to be on April 30th. So if you want to come out and participate, that's going to be an awesome event. So that's for our 5K series. And then really quickly to go over our endurance series, or our endurance events, we have the New York Marathon, which is March 20th. That one's actually sold out, so we had bibs to that, and it completely sold out, but I just wanted to let you guys know that we have that event. We also have the Nashville Rock and Roll, which is on April 30th, and we have 10 bibs left for that one. And then we have the San Francisco Marathon, which is on July 31st, and we have 5 bibs for the full and 20 for the half. So again, if you're interested, you can email Gianna, which is GIANNA at lungcancerfoundation.org for the endurance runs, or just go to our website, click on events, find the location of the event you want to participate in, and then you can find the event website from there. So thank you guys. Hope to see you out and participating in some of those.
Thanks, Katie. One of the other things I want to talk about, I know some of you, again, having been coming here for a long time, remember Brian Kissinger. He was a dear, dear friend of the foundation, and he passed away this past fall, but his sister and his family are having an event here for him, honoring him and supporting the foundation, and it's called Cars for Cancer. There's some flyers for it as you came in. It's actually, we're hosting it here out in the parking lot. It's on March 19th from 11 to 4. It's free of charge. Anybody can come. It's a car show. Brian loved old cars. So they're anticipating anywhere between really 30 and 80 cars. We've got some car clubs driving up from San Diego, bringing all their cars up. There is a Jason Pullen, who's a Harley-Davidson stunt motorcycle rider, will be here doing that. There's going to be a live band, food truck. So it's going to be a really fun day here at the foundation. So if anybody's interested in doing that, there's flyers as you walk in. So with that, I want to start with a little going around the room. I don't know who wants to start. Should we start in the middle, since we always pick on people on the ends, and go through that? If everybody could just tell us your name, who you are, when you were diagnosed, what with, and how you're doing. Any updates, that would be fantastic. Should we? Nobody's volunteering.
Okay, I think you should pick somebody in the back because they're all hiding.
Oh, great. Oh, good. Okay.
Hello, can you hear me? Okay. My name is Larry, and I was diagnosed in April last year with small cell lung cancer. I've seen Dr. Addario, great guy, love him.
Oh, here he is.
I mean, Dr. DORMADY.
Yeah, here he comes.
Yeah, he's here.
And here he is.
We're going to get you mic'd. We're just starting with the around the room. You're in perfect time. You can go ahead. He'll listen
Go ahead.
over there. They're just going to get him mic'd.
My name's Athena, and I was diagnosed the end of 2012, and it's been a little over 3 years now. And I got 2 cancers within about 2 or 3 months of each other, the lung cancer and then the breast cancer. And all I've been on is Tarceva and a couple little pills, and I haven't had to have radiation or chemo.
I'm Karen, and I'm here to support my friend Aluma.
Hi, I'm Aluma, and I was diagnosed in July with non-small cell lung cancer. And about a week ago, I saw my doctor, and it had metastasized to my brain, so I just completed 8 days of a 10-day whole brain radiation treatment. And I'm being treated at Stanford Healthcare. My oncologist is Dr. Wakely, and I'm very glad to be here tonight.
Oh, we're happy to have you.
My name is Angela, and I'm here to learn more.
I'm Ken Artunian. I was diagnosed about 8 months ago with neoendocrine cancer of the lungs, and it has in the past metastasized to the brain, and I'm currently undergoing brain radiation at El Camino Hospital, Dr. Dormandy. And my wife, Marcia.
Yes, I'm Ken's wife, Marcia.
Bridget's coming around with the mic. No, Bridget will grab the back, and then we'll come back around this way.
Oh, this is called playing hot potato with the mic.
My name's Robert. I was diagnosed with non-small cell stage 4 in May of 2014, I believe it was. I'm also a patient of Dr. Dormady's.
Your cheering section is here.
Hi, my name's Rick. I was diagnosed last February with stage 4 lung cancer, adenocarcinoma. Currently being treated at Kaiser Santa Clara. Had surgery, radiation, and I have a PET scan tomorrow.
Hi, my name is Hope Arnold, and my husband had adenocarcinoma, and he was also a patient of Dr. Dormady, who is my favorite oncologist in the world, and I know a lot of them. And I'm here tonight because I'm also looking to talk with folks afterwards if anybody is interested in becoming a tester for a new device that will help people with medication compliance. Just see me afterwards, or Liz or Carla, we're here. Thanks.
Please introduce yourselves. We have some guests from Eli Lilly tonight.
Hi, my name is Holly. I'm with Eli Lilly and Company, and I'm here to learn.
Hi, my name is Darren Edelman, Eli Lilly and Company as well. I lost a grandfather to lung cancer, and I only wish he had been treated by Dr. Dormady. But I'm here to learn tonight a little bit more.
Hi, and I'm Devin, also from Eli Lilly, and I'm here to listen and learn.
Hi, I'm Joyce. I'm from Pfizer. I lost my dad to lung cancer when I was very young, so I'm just here to learn a little bit more tonight. Thanks.
Hello, my name is Yvette, and I'm here to support my mom. She had a coughing attack, so she had to step out. And she was diagnosed with non-small cell January 18th of last year, and she's actually a patient of Dr. DORMADY, and we're very happy to be here. Thank you.
Hi, I'm Sally, and I had non-small cell adenocarcinoma, stage 1A, and had surgery, and I've been doing well for almost 7 years now.
But Sally, you
I'm
were
Carol
in early
Harbian,
detection
and I was
program.
diagnosed in the summer of 2014, and I'm stage 4.
I'm Carol's husband, and Dr. Wakely is our physician at Stanford.
Hi, I'm Jeff, and I'm here to support my wife, Susie, and the others of you here tonight.
Hi, I'm Susie. I was diagnosed in September 2014, stage 4 non-small cell adenocarcinoma, EGFR positive, so I've been on Tarceva this time. And in my mind, that means I've been out 3 years from diagnosis, which it's really only 14 months, but it was 2014, and now it's 2016, so I say 3 years.
Lauren. I've been watching from home for a year and a half, but this is my first time here today.
Yay.
I am, well, I was diagnosed in December 2012 with stage 4 lung cancer, EGFR positive, so I'm on Tarceva. Very fortunately doing great. Used to get some treatment for, Zometa for my bones, and everything's going quite well. Thank you.
Hi, I'm Betty Corner, and in October of 2014, I was diagnosed with oligometastatic adenocarcinoma, EGFR positive, exon 21. I had surgery a year and a month ago, and my last doctor's appointment, my doctor said I could say I was in remission, so I'm real excited about that. Thank you.
Yeah.
My name is Ruth, and my husband, he's been diagnosed with melanoma June 2014. This is Dave.
I'm Dave. I've been dealing with metastatic melanoma, and the best drug that I've been able to take has cleared my breathing substantially and made me more comfortable is Afinitor, which is very expensive. But anyway, my dear friend Patty is helping me out.
I'm Patty, and I heard about Dr. DORMADY from someone that I work with whose mother is his patient, and so we were interested in coming to meet you tonight because we may need another doctor.
Great. We passed on those folks in the back. We didn't.
Does anybody in back want to talk?
We passed you in the back. Does anybody? Okay.
Yeah. I can't see far away when I keep my glasses on.
Hi. I don't know if this is working. Is it?
Yeah.
Okay, my name is Carol, and I thought I would have the longest time span since I was diagnosed in 2011. But, and I've been under the care of Dr. DORMADY since then. It's almost 5 years. I have non-small cell adenocarcinoma, which did eventually metastasize back to the lungs. So I've been on maintenance for a number of years and feeling great and happy to be here for the first time.
Thanks, Carol. Anybody in the back?
In the back? We passed all you three up. Do you want to introduce yourselves or no?
Nobody.
No. Yes. No.
Carol, don't forget looking great too.
Right. And
Yeah,
looking
right?
great.
Okay, we do have somebody back. I don't know if anybody online, Andrea too, if you're ready.
Hi, my name is Mike. I'm with Foundation Medicine, and I'm here to listen and learn.
Peter Morello, Clovis Oncology, also here to listen and hear from all these wonderful patients.
Lori Bryson, and I'm here with my husband, Rick.
Anybody online? Andrea?
Nobody online that wants to introduce themselves, but there are people that I can tell, the ones that aren't sneaky or more private, that are as far east as Florida. So that always warms our heart when people are, when it's 9 o'clock at night and they're still logging in.
Those East Coasters.
Tell Rick
in.
hi.
Yeah, and Karen. So for
I don't
anybody
see Rick
who's
yet.
online watching, this is just another quick little piece of housekeeping. If you would like to chat with Andrea and ask questions of Dr. Dormady as this is going on, in the upper right hand of your screen, there'll be a sign up or sign in button. I can't remember which one it says. And if you just click on it, it takes 2 seconds to create a really quick profile, and that will allow you into the chat room to be able to go ahead and get your questions into us and answered by Dr. Dormady. One of the things I want to point out that I think is really cool, because we've been doing this living room for a long time, and then I'm going to get to you, I promise,
Take your time.
is industry that's in the room. I think, I don't know that if the patients and caregivers in the room understand how unique that is and how inspiring you all are to all of them, and you know, them coming here and interacting with you all and hearing your stories and learning all of these things from you really helps them and gets them recharged and remotivated to go out and work even harder on your behalf. So I think it's really interesting and unique sort of advantage to having an open forum like this.
This is the decade for the patient voice and how important that is. And you know, for the longest time, I know since I've been preaching about the patient voice since 2004, it's really encouraging that in just the last couple of years, it's not lip service anymore. They really do care, and they really do want to hear about your experiences and how they can improve on clinical trials and various different things that they're doing in their own companies. So, you know, this is an open meeting for anybody that wants to come, and the more the merrier, and the more the conversation goes full circle, the better for the patient.
Yeah, and I think, speaking of patient voice, and we kind of talked about this last time, but we always tend to bypass you and your story, and I know you were a patient. You still are a
yes,
patient
I was
based
a
on
patient.
side effects. So I don't know if you
Right.
want to tell your story for some of the new people in the room
Sure.
and online.
I'll do it really, really quick. I was diagnosed in 2004, or Christmas 2003. Stage 3B, tumor was on my aorta and subclavian artery and coming out of my top left lobe. I was told by several people there was nothing they could do for me, but not taking no for an answer, kept looking. It's a much longer story, but I'm shortening it. Went and had a full body scan, found that I did in fact have lung cancer. Took it to my first physician, and they were only talking about, because of the location of my tumor, it was a difficult spot to biopsy. So they wanted to do exploratory surgery. That didn't sound good. So I kept going, and I found an amazing thoracic surgeon up at UCSF. His name is David Jablons. And he was coming down here to Sequoia Hospital in Redwood City to do thoracic surgery on lung cancer patients every Tuesday. So I connected with him, connected with the oncologist that was at Sequoia Hospital, and a radiation oncologist, and they came up with a multidisciplinary plan for me. None of it was easy, but I came out of it alive and committed to change the way that lung cancer is treated and how patients have to work so hard to get the right treatment. And that circles me back to Shane Dormady, because my oncologist at Sequoia Hospital, his name was Fred Marcus. Anybody in the room ever hear of Fred? And yeah, well, he was my oncologist, and he worked with David Jablons and my pulmonary doctor, Melissa Lim, and Lisa Buhar, who was my rad onc. Well, after I got through the knothole and was better, and started the first foundation, Fred joined in, and he was helping us all the way. And then I got a call one night a couple years into that, and Fred was in the emergency room at Stanford, just diagnosed with stage 4 lung cancer. Oncologist, right? Really? And these are the days when everybody is saying you have to smoke to get lung cancer, and you know, there was a profile out there that everybody believed in. So I became Fred's caretaker. And I could go on and on about that story, but Fred passed eventually, and but he got several good years in. And Shane Dormady replaced Fred in the practice that Fred had that included Sequoia Hospital. So he got me ipso facto somehow.
Exactly.
Right. So that's my story. But we are committed here. And it was never about me. It was because I was grateful. I had a difficult a case, and a patient shouldn't ever hear, there's nothing I can do for you. There's always something they can do for you. So never take that. Never take no for an answer.
I think it's interesting from a caregiver's perspective too, you know, with you being my mom and Andre being my sister and Tony standing back over there and watching all of this as it happened and sort of the helplessness we felt, right, during that time when this shared voice wasn't really a thing. Multi-D things, particularly in the community setting, you know, weren't a thing. Targeted therapies were a clinical trial thing, not anything people were regularly talking about. And watching her fight through it, and the whole time she was fighting, saying, when I get out the other side, we are changing this because this is ridiculous and nobody else should have to go through, you know, this to get the care that they deserve. So, so here we are.
And it's working. It's working.
And on March 17th, who else would have surgery on St. Patrick's Day other than...
My mother was in O'Brien, and when they told me it was March 17th, I thought...
another serendipitous moment.
We're
and
good.
It'll be 12 years next month
Yeah.
since the surgery.
Yeah.
So, yeah.
And just one more point, and then Danielle can move forward and
We can stop talking
Dr.
about
Dormady.
ourselves.
You know, the thing that we see in this room, and we started this foundation 10 years ago, we just had our 10th anniversary. It used to be months, not years. And now we're hearing 3 years, 4 years, 5 years. Everybody looks at the survival after 5 years, and it really hasn't been extremely positive because it's only bumped up a notch. But what they're not talking about is between 1 and 5 years, and that is exploding. It is absolutely exploding with mutations, targeted drugs, you know, discovery by some of these amazing pharmaceutical companies and institutions. It's exploding, and to go around the room, I want you to have hope when you hear 3 years, 4 years, 5 years, because I know when some of you came in here, you thought it was days, and you're still here, right? And you're looking good, and you're feeling good, and things are happening.
So with that, I think I'm going to turn things over, thanks Athena, to Dr. Dormady. And some of the things we're going to talk about tonight are the different types of lung cancer, what makes them different, how and why they're treated differently. You know, we spend a lot of time talking about specific things that are kind of revolving around the new discoveries and that sort of thing. And I think it's important to look at lung cancer as a whole and talk about what makes them so different and why they're so different. And I think one of the things typically when we look at, you can get on the internet. And your typical internet search on lung cancer is going to tell you there's 2 types, non-small cell and small cell. That's what they're going to tell you, right? But really, there's all these different subtypes, right? And then even under some of those subtypes, there's molecular subtypes. So it's a super complicated disease all by itself. Lung cancer is most definitely not one disease, right? So I don't know if you want to talk about that a little bit.
Sure. Sure, I was just going to echo a couple statements. I mean, the first of which being it's always an honor to be here, and I don't see the Addarios and the family as much as I like, but I love being here and I love seeing them. And I think Bonnie downplayed her story a little bit. I mean, if you really saw the medical complexity that was associated with her case and the level of creative thinking that had to be applied to achieve the end result, you'd be amazed. So she's a miracle, she really is. And I think you know, it's interesting as we use that as the segue to talk about just treatment in general, and Dr. Marcus, who, you know, a funny story there. I was a fellow at Stanford in training, and you know, here in the Bay Area, the cost of living is you know, very high, and so even as a third-year fellow, I was constantly moonlighting. It was actually a joke at Stanford how much I was moonlighting. I was doing, you know, triple shifts on the bone marrow transplant unit and moonlighting for Palo Alto Medical Foundation on the weekends. And so when Fred was sick, he called Stanford, and his nurse Sherry called Stanford and said, you know, is there a fellow there that would be interested in making a little extra money managing patients? And so what was funny was he called the oncology office, and before they could even get the words out, they said, "No, Shane Dormady, we'll give you his number." And then they called.
2 hours.
Then they called the hematology office, and before they could get the words out, they said, "Oh, Shane, we'll give you his number." So they thought I was the right guy. And then when I went to meet Fred, I just fell in love with him. I fell in love with him, and I can't tell you that when it does circle back to our treatment of lung cancer, lung cancer specifically, but cancer in general, because when I started to meet Fred, or when I met Fred and then started to take care of his patients, I mean, the education I received that year in going through Fred's charts and seeing all the people he had treated, including Bonnie, it was worth 10 years in an academic fellowship, you know, there, and of course you have to learn things by the book, you have to learn what the standard of care is, but then actually going to Fred, and Fred was a genius, I mean, a brilliant oncologist, both interpersonally with patients, but also to sit back and look through his charts, and I'm thinking to myself, I can't believe he did this, and then as you keep turning the pages, I'm like, oh my God, this worked. And you start to realize that in situations that were, you know, in many cases, it didn't seem like there was a lot of hope. Fred would always find the sliver there, and he would navigate towards that direction. You know, he wouldn't say, well, we're going to cure you, but he said, look, this is our only chance to get a long-term, you know, really good result, and we're never going to swing for a single here. We're going to swing for a home run. And I love that approach. You know, I love that approach, and I think in a place, you know, especially in treating lung cancer, where, as Bonnie said, the statistics even 5-6 years ago, you know, you go on the internet and read these things, it's very hopeless. There was no, you know, basically you go to a field of oncology like this where all you can do is go up, and you start to realize, though, wait a minute, in a lot of these situations, we weren't even trying to be creative. And all of a sudden, now we're looking at molecular profiling. We're incorporating radiation, surgery in creative ways. And all of a sudden, like Bonnie says, you start to see these survival numbers explode from years 1 to 5. And at El Camino, even at 5 years, we've tripled and quadrupled the 5-year, you know, outcome rate, so overall survival rate. So just to let you know, there's always hope. And just like Bonnie says, when you go to a doctor and say, well, and they say, well, there's nothing to do, that is the absolute wrong answer, and you should just say thank you, thank you for your time, and move to the next doctor who's going to fight for you, be creative, and really, just like Fred Marcus did, try to navigate, and how I try to do in patterning myself after him, find the way to the home run, not just the single. So, and I would say also one other thing to echo what we've heard. It's great to see industry here, and I think drug companies and big pharmaceutical companies can often get a bad rap, but I would say in my practice as a medical oncologist, not only have I become friends with a lot of the representatives for molecular profiling tests and sales representatives who represent certain drugs, I would say several things. Number one is I believe all of these people truly do care. I mean, there is, there's an element of business in, sort of every facet of medicine, but when you talk to these people, they're asking about patients. They want the best outcome. And I would say that a lot of times they deliver education to me that I don't even have the time to seek out on my own regarding the newest therapies, the newest treatments. And I will also tell you that when I then go to these people advocating for my patients, and I'll tell you that people in this room even have helped me get drugs for free for patients, assisted in, in financial ways, assisted in getting drugs authorized through insurance, used novel gene profiling assays to get patients into clinical trials, helped me find clinical trials. So it really is a team approach, and I would just echo what we're saying up here.
Shane, can I add one thing about Fred Marcus?
Sure.
When he became sick, two things happened that were very revealing to me. He called me one day after he had surgery, and he had surgery with stage 4 lung cancer. And that lasted him quite a while. Mm-hmm. We sent his tissue all over the world. We have a second foundation that is research related, and we're actually driving research ourselves. And we have a collaborative consortium of some of the major thought leaders in lung cancer around the world. We sent his tissue around the world, and he began discussions about his own case with these people. And but after he had surgery, he said to me, he said, Bonnie, he says, I am so sorry. I just didn't know. And he was the best doctor that I could imagine anybody being. But once he walked in our shoes, all he could say was, I'm sorry, I just don't feel like I did enough. Mm-hmm. So, for patients, mm-hmm. Right, and he did. But I mean, if that can be communicated somehow, it's huge. Walk a mile in the shoes of a patient, and we do have industry here tonight. And I know sometimes when patients are talking and communicating, some people think, well, that's a bit annoying, But again, walk in the shoes, sit in that Barco lounger when they put the needles in your arms to start the chemotherapy, go through the surgery, do the radiation, do all these things. And once it happens to you or someone you love, it becomes completely different. Completely different. Sorry. Okay.
Yeah, absolutely. Absolutely.
So with that.
Okay.
Okay. So we want to talk about types of lung cancer. Well, so let me try to frame this in a way that's coherent. So basically, to understand cancer, let's start at the absolute ground floor here. And just looking at Ken, it just made me laugh. I see so many people here that I know. It sort of feels like I'm talking in front of family, so it makes it much easier. You can't say anything wrong when people love you, right?
Right.
That's right.
Okay. At any rate, basically, when you talk about cancer in general, let's start at the ground floor. So I know this is probably too elementary for some people watching or listening, but remember that everything starts on a cellular level. So picture any human being growing from childhood to adulthood, and your body is composed of billions of cells, and the way that you grow is that those cells divide, they grow and replicate, and that's how you grow. Eventually, though, based on the genetic programming, the DNA you inherit from your mother and father, you'll reach a maximum height, and most of the cells in your body then go to sleep. They become quiescent. And whether it's lung cancer or any type of cancer, what then happens is that one cell wakes up. It ignores its programming and decides it's going to wake up and begin dividing uncontrollably again. Now, depending on what type of cell that is, the cell as it grows and divides again, and this time it will not stop growing and dividing. And over time, if nothing is done about it, or as is the problem with many patients with lung cancer, it's not caught in time, because in many instances it's very hard to catch lung cancer. The lungs are an organ that have an incredible amount of reserve. So unless you have a massive tumor in the lung or an innumerable number of tumors in the lung, it's very hard to catch at an early stage. So at any rate, let's get back to the cell types in the lung. So whichever cell becomes dysregulated and begins to grow uncontrollably, it can have different properties. So in the family tree of lung cancer, everything hinges on that one cell. So the first branch point is small cell lung cancer versus non-small cell lung cancer. So when we look at small cell lung cancer, The type of cell that dysregulates or transforms or becomes malignant in that setting is something called a neuroendocrine cell. And as you might hear from the name, a neuroendocrine cell sort of begins from a very primitive cell that can actually differentiate or develop into nerve-type tissue, or endocrine, which is like a gland, like secretory tissue. And that's what leads to some of the very interesting properties of small cell lung cancer. The first property of small cell lung cancer is that it grows with a speed that's almost unrivaled by any type of cancer that can develop in the body. It's one of the fastest growing cancers known to man in medical science. Small cell tumors the most common place for them to develop is in the lung, but they can develop in other parts of the body too. They can develop in the rectum, they can develop in the uterus, they can develop in the cervix specifically of the uterus, they can develop in the ovary, and they can develop in multiple areas of the GI tract, even the appendix. And also, we don't call it technically small cell carcinoma, but a neuroendocrine tumor that grows with great speed, much like small cell carcinoma, can actually develop in the pancreas as well. So one characteristic of small cell carcinoma is its explosive growth rate, such that staging for small cell carcinoma is really just limited to, it's either confined to one radiation field in the lung, where you call it limited stage, versus it's moved out of that field. And that could just mean to lymph nodes on the other side of the chest, but that's called extensive stage small cell lung cancer. So some of the other features of small cell lung cancer that make its behavior unique is that it's notorious for causing what's called paraneoplastic syndromes. And what that means is that little endocrine component of the cells, it can mimic other hormones in the body and start to secrete them into the bloodstream. Probably one of the most common paraneoplastic syndromes that develops with small cell lung cancer is that it can produce and secrete a little protein or hormone that looks like parathyroid hormone. Now, your parathyroid glands are in your neck, sort of situated behind your thyroid gland, and they're important for metabolizing calcium in your body, such that if your calcium levels are low, your parathyroid hormone, your parathyroid gland will secrete parathyroid hormone, and that will cause a little bit of breakdown of the bone and release calcium into your bloodstream. So what the small cell cancer can do is it can produce parathyroid related peptide, which mimics the effect of parathyroid hormone. And so the end result is some patients with small cell lung cancer won't even know they have a lung tumor, but they present to the emergency room with a calcium level that's, almost double what would be considered normal. And that causes confusion and tetany in your muscles, could cause severe abdominal pain, and even seizures in some cases. So that's one example of what small cell lung cancer can do. Another paraneoplastic syndrome related to small cell lung cancer is something called Lambert-Eaton myasthenic syndrome, where you actually develop a sort of repetitive paralysis of the muscles in your body. And so a lot of patients will go to a doctor and say, boy, by the end of the day, it's not that I'm tired, I can't move. I can't move my arms. And certain nerve conduction studies will tell you that this is the type of syndrome that's happening, and it's commonly associated with small cell lung cancer. Another of the syndromes that can be associated with this type of tumor is the inappropriate secretion of a hormone called antidiuretic hormone. And what that means is your body will sort of retain an intravascular amount of fluid, which thereby dilutes your sodium level, and the sodium level will drop. Again, when the sodium level gets very low, what can happen? Seizures, obtundation, alterations in mental status, and so forth. And so those are the types of things that small cell lung cancer can do. Now, it responds to a particular chemotherapeutic combination, a combination of platinum and etoposide. And platinum is a drug that's effective in both small cell and non-small cell lung cancer, and basically the way it works is by breaking DNA strands. It's actually chemically a derivative of the metal platinum. Breaks DNA strands so that cancer cells can't replicate. Etoposide in this setting is, you hear the little cluster of letters there, topo. Well, there's actually an enzyme called topoisomerase that helps unwind DNA so that it can be copied and replicate. And what etoposide does is it knocks out the function of one of these types of enzymes, and that destroys cancer cells. Now, chemotherapy for small cell lung cancer works incredibly well, but the problem with it is you typically don't get durable or long-term responses. So the cancer, can actually evaporate when you get chemotherapy, and then just 4 to 6 months later, though, you can end up with more trouble. And so you rapidly move through different chemotherapeutic recipes, and that's why the prognosis for small cell lung cancer is still a little challenging.
I have a question.
Sure.
Sorry. So, is there ever a time when surgery is done on small cell lung cancer patients, or some combination thereof, surgery, chemo, radiation, like you would see in some non-small cell?
Typically no. We used to do surgery for small cell lung cancer, but that was decades ago. That was before sort of the advent of newer radiation technologies and the discovery that small cell carcinoma was just as sensitive to radiation as it was to chemo. So if you're lucky enough to catch a small cell carcinoma before it's moved into the mediastinal lymph nodes or out of that one radiation field we talked about, the standard of care is to use the drugs we talked about, platinum and etoposide, and then couple that with radiation. And you can cure small cell lung cancer by doing that, if you're lucky enough to catch it at an early stage. I mean, I never want to say never. If someone with small cell lung cancer were to undergo that sort of chemoradiation protocol and then had some kind of local recurrence in the lung, an isolated spot, it's not inconceivable, because you couldn't do more radiation to that area to maybe do surgery in that setting, again, if you were thinking creatively. But it's not the standard approach to do surgery for small cell.
And is that typically because of the aggressive nature of small
Right,
cell?
it's sort of like when small cell is diagnosed, you're almost already thinking of it as a systemic disease. No matter where you see one spot there, you're still thinking of it as a systemic disease. Even if you have a tiny 9mm spot of small cell carcinoma, pretty much anywhere in the body, you're unloading the holster and firing everything you have at it, radiation, chemotherapy, and just hoping that because it was so small, when the smoke clears, you'll be lucky enough to have destroyed any remaining cells. But that's the point. It's more of a systemic disease than a local one.
Gotcha.
Any questions about small cell lung cancer? Did anyone ask?
Neuroendocrine, is that a small cell?
So, Ken, very good question. So, and we've discussed this together, that there's sort of a continuum of neuroendocrine tumors. There are ones that grow very slowly and can originate in the lung. I mean, so slowly that the growth rate is barely detectable, and those are called carcinoid tumors. So you have that on one end of the spectrum. Then you have what's called a large cell neuroendocrine tumor that can grow with great speed and behave in many ways similarly to small cell lung cancer, but maybe just with respect to growth rate, just a hair less aggressive, but still has the same sort of growth pattern, metastasis pattern, probably a little less incidence of those paraneoplastic syndromes that we were talking about, but still responds to the same drugs as small cell lung cancer, the platinum and etoposide. Again, usually response rates up front are very good, but the trick is the durability response rates. And that's why, and again, this is just a stylistic approach to treatment with small cell and neuroendocrine tumors. What I tend to do, I've found that after giving a patient aggressive chemotherapy with platinum and etoposide up front, one creative thing you can do, not considered the standard of care, but is to potentially place patients on a maintenance form of therapy, the oral form of the drug etoposide. And what I found is that maintains patients in remission for a longer period of time, and it prevents aggressive relapses. It's sort of like even if the cancer is going to recur, it recurs in a bit more of a controlled fashion than if you're not on maintenance therapy. So, yeah, there's a continuum of different cell types there. Okay. Any other questions about neuroendocrine tumors or the like? No? Okay, because then we can sort of drift into, what really amounts to the majority of cases of lung cancer, which would be non-small cell lung cancer. You can sort of see in the nomenclature, it's sort of like you have small cell lung cancer, which is hard to deal with, or you have everything else. And within non-small cell lung cancer, there are not just one or two subtypes. I mean, depending on how detailed you want to get with the pathology, you can probably drift into 15 or even 20 subtypes. But broadly speaking, there are several types that are most common. Now, the most common type of non-small cell lung cancer is adenocarcinoma. And adenocarcinoma, let's think again about the cell of origin. So with an adenocarcinoma, the cell that transforms or becomes malignant is related to sort of the glandular mucus-forming cells in the lung, okay? And those types of cells, as you can imagine, are more prominent, more prevalent as you get into the outer layer or outer periphery of the lung. So adenocarcinomas are most commonly located in the periphery of the lung. And they are the ones that are most commonly seen in non-smokers, most commonly seen in women. No, let me rephrase that. It's not that they're most commonly seen in women, but in women who have lung cancer, they are clearly the most common subtype. And it's within this area of lung cancer treatment where we've had some of our greatest breakthroughs recently. The gene mutations that we talk about all the time in the living room here and in the clinic and academic centers, the epidermal growth factor receptor mutation, the ALK1 gene mutation, the ROS1 gene mutation, and others that are being studied, predominantly, if not, I hate saying exclusively, but predominantly these are found in adenocarcinomas. And so here is where the greatest breakthroughs have come with respect to targeted molecular therapy. Instead of the carpet bombing that some chemotherapy can tend to be, you're really just giving poisons that work on rapidly growing cells and hoping that you affect the cancer more than you affect normal cells. Whereas with the gene mutations, these are guided missiles. I mean, you're targeting the cancer cells specifically. And it's not that these drugs don't have side effects, but in general, they tend to be much better tolerated than chemotherapy, infusional chemotherapy. The treatment for adenocarcinoma is really going to be based, sort of stage for stage, and even with the excitement that's sort of been engendered by the gene mutations, what we've tried to do is say, hey, if you have an early stage lung cancer as opposed to the patients who have stage 4 disease, which is almost exclusively where the gene mutations are being exploited and used, and where drugs like Tarceva and crizotinib and Zycadia and all of these drugs are being used. What if if you have the right gene mutation, what if we do all the right treatments, surgery and or chemotherapy, but then additionally add the targeted therapy to that. And I mean, I was a huge fan of that approach. I've even tried it in several patients. I know it's become sort of the idea behind many clinical trials where they're exploring this principle these days, but surprisingly, you know, that's what you think you have the breakthrough and you think it's always going to pan out the way you expect, but so far we've had trouble showing that the addition of targeted therapy in earlier stage disease has produced therapeutic benefits. So that's sort of interesting and a little bit unexpected, frankly, but certainly as you go on with stage 4 disease and in some patients with stage 3 disease, these targets are life-saving. And I think here more than with anything else, patients who have these mutations are the ones who are taking these survival curves and really breaking them. And patients who were living, you know, 3 months, 4 months, and 6 months, I mean, really just that short a period of time, are now living 2 years, 3 years, 4 years, 6 years, 7 years, right?
So I have a question on the topic of adeno, because that's where we are. You know, we talk a lot about targeted therapies, and this is where sort of the breakthroughs are. But then when I think back to your case, right, we don't know, right? We don't know. And you were diagnosed at 3B, who, you know, 3B patients back then were basically told what you were told. Like, we can try to throw some chemo at you, but you should probably get your affairs in order, right? So I guess in that instance, and you being somebody who thinks outside of the box, even with your patients, and in your opinion, your patients, even regardless of whether or not they have a fusion or a mutation, and I want to talk a little bit about management of disease across the board when we get through the types, but it can be, I think a lot of people get really caught up on whether or not they have a mutation, and that's sort of the basis for where their hope will lie. And I just think that you're a good example of why that doesn't necessarily have to be the case, because each patient is individual. I just want your opinion on that.
Yeah. But I had a team that also went outside the box, and they did some very radical things that weren't considered standard of care either. You know, I had chemotherapy every Friday, not every 3 weeks, every Friday, and a double dose to start, and then some, and radiation during that time. I was having chemotherapy every Friday. I was having radiation every day. So that wasn't standard of care either. So, and I think Danielle brought up a good point, you know, because we hear too often when people are very encouraged about being tested, and then they find out they don't have one of these targets, that, you know, that's not a good thing. But some of the things that are happening with trying different cocktails and clinical trials and various different things are also extending lives.
Absolutely.
Right?
Absolutely. Well, a couple things I can say about that. I mean, one would be, you know, when you're excited to sit down for Thanksgiving dinner and you get all the food on the plate, but you forgot the gravy, well, you're still excited about Thanksgiving dinner and how creatively you can put things together. I think the gene mutations are the gravy. You know, you can put that on everything, and that's sort of the icing on the cake, and you know, you get excited that, you know, there are these various and sundry possibilities, but that doesn't mean you don't have a nice dinner in front of you if you don't have the gravy. I just tell patients, look, the gene mutations, that's wonderful if we have one. If we don't have one, that doesn't mean we're not going to be creative. We're not going to bend the rules or outwardly, you know, overtly break them in some cases to think creatively about you. Nothing's off the table. Now, let me be very clear. It's not that surgery, radiation, and chemotherapy shuffled or combined or that sort of thing is the appropriate treatment plan for every patient. You know, there are some patients when they present, you know, it's really based on the number of metastases they may have with stage 4 disease and where they're located. And, you know, sometimes you really just have to realize that you're in a bit of trouble and do your best to keep the disease controlled. And that's okay too. I mean, I just tell patients that's okay. Look, yes, we have a lot of areas of concern. You know, there's some patients where I've said to them, look, you know, in some cases you have to laugh to keep from crying, and we've sort of chuckled together, and you look at the PET scan, and you just have to put your arm around the patient and say, look, there's really not an area of your body that's not affected by the cancer, and you just have to just go through it together and say, that's what it is, but okay, that's fine. Even though the scan looks a little exciting right now, more than we'd want it to be, what we need to do is still be creative, manage your side effects and symptoms accordingly, be really aggressive with that, and all we're gonna do, maybe we can't cure this disease, but we're gonna try to turn it into high blood pressure, diabetes. We're gonna turn it into, as long as you get your treatments, it's under control, and we're gonna try to put it in remission.
So I think I just want to touch on this really quick because I think a couple of things you said sparked, some thoughts in my head. One, how important that shared voice conversation that we're talking about is, right? In having that conversation with patients, what are your goals? What are you looking to get out of this? How aggressive you want to be? But also, I think a lot of times patients in talking to them, well, I met so-and-so at a support group or whatever, and technically they have the same exact cancer as me, but their doctor is doing A, B, C, and D, being super aggressive, and my doctor's saying no. So can you talk a little bit about how you kind of gauge how aggressive when does being too aggressive become worse than the cancer itself? Maybe ECOG scores and how you kind of gauge what might be too aggressive for a patient based on other, outlying issues around the diagnosis.
Sure. Well, I think that as a medical oncologist, really I try, it's sort of just my approach, to be extremely aggressive. I know that that's the reputation that I've sort of developed in the community. It's sort of like if 99 medical oncologists said there was no hope and there's no treatment. Well, you should see DORMADY, he'll do something. But I try to convey that my approach is not one of blind aggressiveness. It's more one of, here the patient presents to me, and maybe they're not doing wonderfully at the time they hit the door for the first meeting. Maybe they're having a lot of symptoms from the cancer itself. My point is that I can do something, just like Bonnie's saying. And the onus is on me as your medical oncologist to say, yeah, I'm gonna treat you. I'm not gonna use the full dose of chemotherapy. Maybe I'm not gonna use 3 drugs, but maybe I'm gonna use 2. And instead of walloping you every 3 weeks with massive doses of the drugs, thereby producing more side effects and maybe doing more harm than good, no, we're not gonna do that. We're gonna treat you 2 weeks in a row and have a week off, lower doses. Or we're gonna treat you every other week. Again, the onus is on me. And I'm gonna watch you closely every week, check your blood tests, really be hyper vigilant, and we're gonna see what we can do. As you start to improve, then more treatment options come on the table. So I think, and just every doctor is different. There are some doctors who, and medical oncologists, which always surprises me, who will take a more nihilistic approach to cancer, and I've never understood that. I mean, if you're not gonna be an optimist and you go into the field of oncology, you probably picked the wrong job there. But
Shane, aren't we talking about, and I hate to skip ahead because I know we still have to talk about squamous cell and some other lung cancers, but aren't we talking about personalized medicine?
Absolutely.
Looking at the whole patient and looking at everything going on there. Okay, they have lung cancer, but is there diabetes? Are there any other illnesses? How is their health? Are they fit? Are they healthy otherwise? So many things to look at. And that's what we're talking about. We're talking about the whole patient.
Well, we're absolutely talking about that. I think my point is this. There are patients who have come to me and they've said, Dr. Dormady, look, I really don't want to be that aggressive. I'm 80 or 82. I've lived a full life. And I mean, I respect that. I am not there trying to sell treatment to patients. And I say, I completely understand. If your goal is to maybe do a little something gentle, keep things under control, you want to try to make it to your granddaughter's wedding in 3 months, and then let's do that. Let's keep your symptoms controlled. I know exactly what we can do. If a patient comes in, and even if they're feeling poorly, they say, look, Shane, I really want to fight this. And with my last breath, if I'm in the chemotherapy chair, that's okay with me. I have nothing to lose.
Right.
And then I say, okay, then the onus is on me to figure out how to safely treat that person. So, that's why I bristle when some doctors will say, oh, well, you're treating that person? Well, yeah, I'm treating them. I'm not treating them with standard protocols, but we're gonna do something a little creative and lower dose, and we're gonna make it work. We're gonna make it happen. So Personalized medicine, absolutely.
Yeah.
Personalized not always in the sense of gene mutations in PET scans, but personalized to what's in someone's heart. And I can tell you, you only have to practice oncology for a very short period of time to know that so much of this goes beyond gene mutations and drugs and chemotherapy and surgery. Patients will will themselves to live and do well, and I've seen it time and time again. So my job there is if I have that type of personality and I'm working with that type of patient, I'm never going to be the person to dampen that emotion. I'm going to say, how are we going to do this? And sort of try to synergize with those people.
Yeah.
So
I do want to talk a little bit about managing care and the role of, supportive care in that management sort of across the board, but
sure, why don't I finish up? Why don't we just finish off just touch on two other very common subtypes of non-small cell lung cancer. The next most common would be squamous cell carcinoma of the lung. So we can highlight some of the differences between adenocarcinoma and squamous cell carcinoma. So my favorite thing to talk about, I was a classics major in college, so I like to talk about Latin and ancient Greek. So it's interesting to note that the word squamous actually comes from the ancient Greek word for scale or armor. And that makes sense, because where do you find squamous cells in the body? You find them everywhere where you need a little bit of protection from the environment. It's in places where your body can come into contact with, food products, open air, things you inhale. So where are squamous cells? Where the biggest collection of squamous cells are on your skin.
That's right.
Then there's no greater area where we need protection from the environment. But you also find squamous cells in other places like the esophagus, where you're swallowing food, the trachea. And so getting back to lung cancer, where you see squamous cells are you see them in the nasal passages, the sinuses, the oropharynx, the trachea, and then in the bigger or main stem bronchi and the bigger bronchial tubes here. Remember how we said that adenocarcinoma was more peripherally located? Squamous cell carcinomas do tend to be more centrally located. And you can often present with a large mass in the middle of the chest or just eccentric to that, to one side or the other. And squamous cell carcinomas a little more commonly do present with that larger, very bulky primary tumor, less so with smaller peripherally located tumors. And I have seen in patients with squamous cell carcinoma a little higher incidence of the paraneoplastic syndromes again. Most commonly I've seen hypercalcemia, or high calcium levels in the blood. Squamous cell carcinoma does behave a little differently with respect to treatment. And this is where I balk a little bit at saying no squamous cell carcinoma ever has the 3 gene mutations we talked about.
Because they do.
Because I've heard pathologists say that and others, experts in the field, and yet, it's not that I'm trying to paint with broad strokes in the clinic, but I'm always thinking, well, wait a minute. Now, what if this patient in front of me, whom I'm trying to treat like a family member, what if they're the one person who has the gene mutation that's more commonly seen in adenocarcinoma, but they have it in the squamous cell carcinoma? Why not just run the molecular profiling? And I had a patient where the pathology was reviewed in multiple sites, and they said it was squamous cell carcinoma, and yet they had an EGFR mutation. And so I started him on chemotherapy with Erbitux, which is an infusional EGFR antagonist, and he's had a miraculous response. We put him on maintenance therapy with Tarceva, and he's still in complete remission. So I think it's always worthwhile in just about any lung cancer case to just run the molecular profiling. Whatever assay you use, whether it be Caris Diagnostics, Foundation One, you just identify targets for therapy. And even if you don't pick up one of the more common gene mutations, you can pick up others that are actionable targets.
Well, we're circling back again to an informed decision, between the patient and the oncologist. But even for you to say, I need all the tools in the box examined. I need to know if there's mutations. I need to know X, Y, and Z. So the decision that's made is one that's informed rather than guessing.
Exactly.
Right?
Exactly. And it's also important to note that sometimes you'll have a mixture of adenocarcinoma and squamous cell carcinoma. You can have adenosquamous carcinomas. And if you have a tumor that's 5 centimeters in size, there can be sampling area. You know, you take a biopsy and you get predominantly squamous cells. You think it's only a squamous cell carcinoma, and then later on, let's say that patient has the full tumor resected, and you say, oh my gosh, there's a proportion of cells here that are adenocarcinoma. And so you just never know, and that's why I do try to send the gene mutations on everyone. But squamous cell carcinoma, you know, you typically will use similar drugs in treating adenocarcinoma and squamous cell carcinoma. You know, 7, 8 years ago, we had a series of publications suggesting that platinum coupled with the drug Alimta, with or without the use of newer biologic agents like Avastin, may be the best first-line treatment when you're using chemotherapy for adenocarcinoma. Whereas with squamous cell carcinoma, it didn't seem that that was quite the case, and that alternate or older, more conventional recipes like platinum and Taxol or platinum and gemcitabine seem to be potentially a little more effective. They also found that using angiogenesis inhibitors like Avastin, now what does that mean? We throw these terms around. Inhibition of angiogenesis is a trick we can use to sometimes defeat cancer cells, because one of their greatest tools is to use certain hormones that they can produce to create their own blood supply, their own food lines, oxygen lines, and so forth. And when you use drugs like Avastin, or the newer drug ramucirumab, Cyramza, you can start to block those supply lines and synergize with the chemotherapy. But what we found with squamous cell carcinoma, at least initially, was that patients were suffering from, in some cases, life-threatening episodes of hemoptysis, or coughing up blood, when they used these angiogenesis inhibitors. And it wasn't clear if that was because the actual response on a cellular level was different with squamous cell carcinoma, or was it simply an anatomic thing where these larger tumors were so much more centrally located that as they started to shrink or hemorrhage a little or necrose as the drugs worked, they could bleed, and when they bled, it was central and bigger arteries were involved, and then you'd have a much more serious problem. So the biologic agents like Avastin and others that are angiogenesis inhibitors haven't been used as frequently with squamous cell carcinoma. One recipe, though, that I've had great success with, even in the absence of the epidermal growth factor receptor mutation for squamous cell carcinoma, is the use of platinum, Taxol, and the epidermal growth factor antagonist Erbitux. And I've coupled those three together in various ways and had really wonderful responses. I think one of the most exciting things about treating squamous cell carcinoma these days has been the advent of immunotherapy. And that initially, what is immunotherapy? Well, just broadly speaking, that's sort of training or enhancing or supercharging your own immune system's ability to fight cancer. You might think, well, how's that going to work? Well, it's interesting. You know, we know that our immune system plays an incredibly important role in the surveillance and destruction of tumor cells. Now, how do we know that? Because when you look at children who have severe immune deficiencies, they will develop cancer at a much higher rate. When HIV and AIDS was epidemic, what happened to a lot of those patients? They would develop bizarre forms of cancer and lymphomas, Kaposi's sarcomas. And additionally, when you look at mice where you knock out elements of their immune system genetically, they will develop all kinds of tumors. So clearly, the immune system is doing something throughout all of our lives to surveil and destroy developing cancer cells. So by enhancing that effect, you know, you're thinking that maybe this could be one of the most potent treatments of all. You train your own set of police, your own immune system to travel through your body, and those white blood cells that you enhance are really going to go everywhere a cancer cell can hide, and in theory destroy them. So the newer classes of molecules, these PD-1 inhibitors, sort of enhance a couple things. Enhance the body's own ability to detect the cancer cells, and also tumor cells are incredibly resilient and sneaky. They can find ways to mask their appearance in the body, and these newer drugs, many people think, are taking away some of those layers of shielding, so that not only are your immune cells more effective at finding the cancer cells are also more sort of naked and less hidden and can be detected more easily. I have to say, my only concern about the immunotherapies as I've watched them be implemented is that this effect where you supercharge the immune system takes, for the average patient, a fair amount of time. It can take anywhere from 6 to 12 weeks to really supercharge the immune system and get these drugs to work. And some patients, when the disease has either been heavily pretreated with other drugs or it's just rollicking or galloping out of control, you don't have that much time. So I think a lot of emphasis now is being placed on, what other things can be coupled with the immunotherapies to sort of keep the disease at bay while waiting for the immunotherapy to kick in. Things like our targeted therapies, Tarceva, biologic therapy, Avastin. And you have to be careful. You don't want to use things that are going to slow down the immune system. So I think conceptually we're having a hard time saying, well, how can we combine chemotherapy and immunotherapy at the same time when chemotherapy is slowing down the immune system, but we're trying to boost it? You're sort of at cross purposes there. But that's all being studied.
It's all lots of trials out
Yeah,
there.
and I have to say, again, just to inspire hope, you just never, the human body is so unpredictable. I saw a patient just probably 2 weeks ago where he voluntarily said, I understand I have stage 4 disease and the cancer is behaving rather aggressively, but you know what? I don't want chemotherapy. He just didn't want chemotherapy. And he said, I want immunotherapy. So he enrolled in a trial that randomized him into either chemotherapy or immunotherapy. He was randomized into the immunotherapy arm first line with the disease sort of galloping, and he responded. And it's been a year now and everything's been under control. And just to sort of illustrate another point, where he's being treated, 2 areas of disease, one in the lung and a node in the middle of his chest, after 1 year are growing. And his team told him, well, you're progressing, let's can the immunotherapy, let's move to something else. Well, I said, no, I disagree with that. The immunotherapy is working amazingly well with the innumerable other spots in your body. You have 2 that are growing disproportionately. That's what CyberKnife was made for.
Right,
You
exactly.
cherry pick those spots.
Right.
They can be targeted, and in some series of data, CyberKnife is more effective at local control than even surgery.
Right.
And so target those 2 spots with radiation and stay on the immunotherapy. If we're dealing with a finite number of cards in our hand with stage 4 disease, you can't give up on one until you've exhausted every iota of effectiveness. So that's the sort of thinking you want in your team.
Because the drug is working on the primary tumor, the one that was found initially, and you metastasized, and that drug just doesn't cross that brain barrier. So that's when you bring in the CyberKnife and leave the drug alone because it's holding back the primary tumor.
Right, and it doesn't even have to be the brain. I'm talking
Right,
about
it could be-
CyberKnife
right,
and tumors
exactly,
in the chest,
yeah, yeah.
or the liver, the bone.
Yeah.
Oh, so we need a mic.
You have to have the right mutation for that.
For
a certain immunotherapy drug.
So depending on which drug you use, some sort of mandate that you're tested for this PD-1 expression before the drug is used, but others don't. What we've seen is that the drug tends to be more effective when you have PD-1 expression, regardless of which specific drug you use for immunotherapy, but that it can work even in the absence of, or with less expression of that molecule. But that's a very good question. Initially, the thinking was it would only work if you had expression of PD-1, but That's not proving to be the case as we study things more and more.
I just tested once, for mutations, it's made in it's been retested for that, or if so, at what point?
So that's a super good question. The question was, initially, if a patient is tested for certain gene mutations, should they be tested again? I think that it's absolutely a certainty that new mutations can develop in tumor cells as time goes on and as you receive more treatment. The tumor cells do have adaptive mechanisms that whereby they learn how to get around or circumnavigate drugs. They can take them into the outer portion of the cell and pump them right back out. And certain mutations will evolve over time as the cancer cells see more and more therapy. Now, let's divide this into answering your question two ways. Have I seen patients over time develop the epidermal growth factor receptor mutation or ALK1 mutation or ROS1 mutation, the ones that would probably be most important therapeutically? I really haven't seen that. But do the tumor cells change over time such that if you do molecular profiling, there could be new targets for novel clinical trials or other agents? Yeah.
Shane, could it be too that in the original biopsy, they really didn't get enough tissue to identify?
Oh, that's a super good point.
Right?
Yeah, that's a really good point.
Yeah.
I think Bonnie brings up a great point. You have to make sure that on your first biopsy, there was an adequate amount of tissue, and that's such a good point. What I've found with some of the newer biopsy techniques, such as three-dimensional bronchoscopy, endobronchial ultrasound, they're great. They're great if you get a good piece of tissue, but that oftentimes you won't. And then that does call into question the accuracy or validity of the initial genetic testing. And should you be tested up front again, immediately with a bigger core biopsy where the pathologist says, okay, there's a ton of tissue here, there's going to be no uncertainty or vagary about the gene results. So absolutely, if there was any question of adequacy of the sample, you should have another biopsy as soon as possible. Your question, though, down the line, should you be retested? I think yes. I think that's reasonable. I've done that with patients, too.
With the lack of tissue,
Excuse me?
if there's a lack of tissue,
Well, even the biopsy techniques are evolving such that we're now talking about liquid biopsies that can be done on blood samples. They can be done just with a peripheral blood test. There are some a little bit more invasive techniques where interventional radiologists will biopsy the tumor but take blood samples from neighboring blood vessels to sort of do more genetic profiling. And so I think even the biopsy techniques are evolving rapidly over time. So you may not even have to undergo another invasive procedure to get your biopsy or to get the genetic profiling retested. I have to say, we actually discussed a case recently in my office where there are two different companies, one doing a liquid biopsy, one doing genetic profiling on a solid biopsy, and I was amazed to see the concordance or the agreement between the two tests. So I think the technology of liquid biopsies is quite valid, and it's up and coming.
I've seen many patients, and some are online today, that were tested for the T790 mutation, showed up in the blood, but they were denied going into a clinical trial because the protocol for the trial said it had to be in tissue.
Right.
So later on, they missed the trial, but later on, when they progressed and they got a new biopsy, there was the T790 in the tissue.
Yeah. There you go. I'm sure over time these liquid biopsies, the technology is catching on, and it seems to be accurate. It seems to be valid.
Yeah.
I think Andrea has a question from online.
Okay, I have a few. Any recommendation for an EGFR positive patient who progressed on Tarceva, but also tested positive for T790 and 60% positive cells for PD-L1?
Well, sure. I think there are a lot of things. Well,
It's a young patient, too.
A young patient, okay. with respect to the epidermal growth factor receptor mutation, or many of these mutations, I think there are two differing schools of thought. In many cases, when a patient has stage 4 disease and multiple areas of involvement in the body, and you have a gene mutation, there's one school of thought that thinks, hey, let's jump in there right away. We have this magic bullet. We need to get this situation under control. Let's go in and use Tarceva, crizotinib, up front. There's a second school of thought adopted by many brilliant oncologists, including the one sitting in the room here. But I think that my experience is that the patients with the gene mutations actually respond better to chemotherapy as well. And when you have, in some situations, an overwhelming tumor burden, oftentimes I recommend starting with chemotherapy before switching over to some of the targeted therapies. I've found that the targeted therapies seem to work much better when you're dealing with a smaller number of malignant cells or a smaller tumor burden. And I found that not only do they work better, but the response is more durable. It lasts longer. I've had trouble with patients who have bulkier tumors or a lot of disease where you start with targeted therapy and keeping that disease controlled for a longer period of time. Regardless, in this situation, there are other EGFR blockers. There's the newer drug afatinib. There are drugs that specifically target the T790 mutation. And I think if that mutation is present in those tumor cells, that may be the next best approach to try to target the T790 pathway. I've had a lot of patients who've enrolled in clinical trials and tried to exploit that pathway who've had good responses with the newer drugs being used there. I think after that, moving towards immunotherapy would be a reasonable approach. But for this patient, I don't know if they've had chemotherapy yet, but don't abandon that avenue as well. I mean, chemotherapy also gets a bad rap. Even earlier today, I called it carpet bombing. But in many patients, the tumor cells are so exquisitely sensitive to one versus another drug that I wouldn't divulge any personal information on any patient, but I can tell you that many people, here have benefited from the use of long-term chemotherapy and have tolerated it well, even for years.
Right.
So with this patient, I'd probably move towards the T790 pathway. After that, I would likely use chemotherapy, and then when the disease is more controlled, maybe move on to immunotherapy.
Okay, so he did want to comment that he was originally negative for T790 in the tissue, but was positive for it in the blood biopsy, and he has not had chemotherapy. His original treatment path was Tarceva. So
yeah,
he just wanted me to add
so
that.
Patients with this mutation, just to be more clear about it, they tend to, even though it looks like they have an EGFR, or in some cases you'll have a concurrent EGFR mutation and the T790 mutation, or just the T790 mutation. And in the patients with both, they'll respond very poorly to EGFR targeted drugs. And in the absence of that, these newer drugs that are being developed can work very specifically on that mutation. I would say that's kind of the more direct pathway to attacking that patient's tumor cells, more personalized. But again, that patient should have chemotherapy at some point and immunotherapy as well. Okay. You just want to exhaust all of your options. The sequencing of those options can be stylistic from oncologist to oncologist, but using all of them is the key.
And Shane, for the new patients that are online or in the room, you shouldn't think of chemotherapy as your grandfather's chemotherapy, right? Because of all of the things we have now to manage side effects and make them even almost disappear. It's much easier to tolerate now.
You're pretty knowledgeable. So just to speak to Bonnie's point, I do see that as well. Some people, just like the patient I mentioned earlier, who started with first-line immunotherapy, a lot of people just have in their mind that chemotherapy is going to make them violently ill, and in many cases, the combinations for lung cancer don't even cause your hair to fall out. And Bonnie's right. The drugs to prevent nausea and manage side effects have evolved to such a degree that I really do try to tell patients, I think that if you have nausea that we can't control, then I did something wrong. It's not the chemotherapy's fault, it's my fault.
Take all those movies you saw on TV and Channel 46 Lifeline.
Yeah, I think
take it out of your mind.
Yeah, I want to touch on something that Shane just said though, because I think it's important across the board, regardless of what your type or subtype is. You know, you look at 2015, and we talked about this last month, was a pretty exciting time for lung cancer. There were 7 new drugs approved, right? You know, running across the board, immunotherapy, second gen, targeted therapies. Nessie was approved, Lilly's drug for squamous. There's been a lot of exciting things that happen in a short period of time, in the last 12, 13 months now, right?
More to come.
And there's more to come, and I think it points back to managing the disease, regardless of subtypes. You know, you've got industry working hard on. I had a patient say to me one time, and he's a young patient, and he said, you know, my goal is to stay on any one drug as long as I can till I have to move to the next, and then the next, and the next, for however long that drug will work with me, because I just need to get through them until the next one comes out.
Chronically
right?
managed.
It's, yeah, you know?
Hoping.
Yeah, that's exactly right. I agree. And I try to tell patients that because you can feel hopeless when you're just diagnosed, and you just have to really frame the goals correctly and say, you know, please don't be discouraged. We haven't even started your treatment yet. And even with a lot of disease, the cells can be so exquisitely sensitive to treatment. Just hang tight. We can regroup after your first PET scan or CT scans and see how you're responding to therapy. And many of those patients have such a profound response. If they can just hang on to that first scan, and you can say, look, you know, it's really working. And then they get some wind in their sails and start to believe that, oh my gosh, you know what, we can control this. And then you do exactly what Bonnie and Danielle are saying, and what I'm trying to stress to the patient who asked the question over the internet. Whatever sequencing you do with your treatments, just make sure you use all of them and use them until, you know, really hang on to them until there's clear evidence, irrefutable evidence that they're not working anymore. Because that's how you win the chess match, and you make it to the next drug that's developed. You make it to the next event in your life, the granddaughter's wedding we talked about, or just waiting for the next therapy to come along, and you just hang in there.
And maybe even reusing a drug that worked really well in the beginning and you progressed, that now your immune system has forgotten about it, and you can use it again.
Yeah, you're so right, Bonnie. I mean, that is a good trick. Now, sometimes that doesn't work quite as well, but it is something you can do. You can recycle drugs, you can put them into, because cancer cells, as you know, we sort of anthropomorphize them and make them people here, or smart or stupid, but you know, they do have a certain adaptive or evolutionary mechanism to beat the drugs, and then we sort of think, wow, the cancer cells have become smart to that drug, they've outsmarted it. But when you start to push and come at them from a different direction or mechanism of action, Bonnie's exactly right. Then they sort of shift a lot of their genetic energy towards defeating that drug. And over time, you can go back and recycle a drug that you used in the beginning. Now, typically, the response won't be as long or durable as it was in the beginning, but just what we're talking about. Are we talking about buying 2 months, 3 months, 6 months until the next therapy comes down the pike? Absolutely. Have I watched it work in patients? Yes. So this is not just theory, and we're saying what people want to hear.
Well, and I think it's important too, because the management part is also, we talk to patients all the time who don't qualify for one trial or another based on what line of therapy they're on, or what treatments they've already had, or where in the body their disease is. So if we can use some of these already approved drugs to get them through until those drugs then get approval and can be readily, do you know what I'm saying? I mean, I think it's all
absolutely. I mean, the best example recently was, you know, just like we talked about with PD-1 expression. Initially, when those drugs came out, it was sort of like only for squamous cell, only with PD-1 expression. Well, even that's evolved now to where you don't necessarily have to demonstrate that. The drugs will work anyway. You can still use them. It's now approved for use with adenocarcinoma, and you know, so even in a short period of time, there can be evolutions to the story.
Andre's
and always have hope.
Some more,
Andre, you have more questions?
I do. One question from a patient who's KRAS positive in her left lung, right lung, not. In the right lung, I'm assuming biopsy was not positive. As we know, there isn't any immunotherapies targeting KRAS at this time. However, if he or she were to need a plan B, are there any targeted drugs that may be worth a try?
Okay, so the KRAS mutation tends to have garnered a little more press in the field of colon cancer, where if it's present, if you have a mutation in the KRAS gene, you typically won't use the epidermal growth factor blocker Erbitux or cetuximab, which has been found to be very effective for patients who don't have a KRAS mutation with colon cancer. Now, in lung cancer, there's the KRAS gene and mutation seemed to get a little more press a few years ago, whereby we thought the same thing. If you have that mutation, you're not going to respond as well to EGFR blockade or epidermal growth factor receptor targeted therapies. I also am not aware of a conventional drug that's been approved for use by the FDA for the KRAS mutation, and I think a lot of the clinical trials have shifted towards more like the T790 mutation and those sorts of things in terms of overcoming EGFR resistance. So I can't specifically recommend a drug that targets KRAS, but again, I would just sort of circle back to the chemotherapeutic approach. The KRAS mutation doesn't exclude a patient like that from immunotherapy. Using angiogenesis inhibitors, Avastin, Cyramza, what have you, those are still on the table. And, you know, again, I don't know the details of the case, but, you know, trying to creatively incorporate radiation in some cases, if there's oligometastatic disease, meaning there are just a few sites of disease, then that's reasonable too.
I have a question to that question. Is it normal for one side to be KRAS and then the other side to be something else, or is there the potential for being two separate
That's a super good question.
primaries?
I mean, again, when, you know, just seeing patients and just garnering experience over the years, you just see everything. You see absolutely everything. And what you'll see is that in certain patients, now I don't know this particular patient's history, but especially in patients where there is a bit of a heavy smoking history, you start to develop a field defect in the lungs where you almost get areas of precancer developing in multiple places. And in those patients, developing synchronous but different primary tumors can happen. One of my patients developed a large cell neuroendocrine tumor on one side of his chest, and then on the other side, right at the bottom, he had a squamous cell carcinoma. And so we had to sort of treat the neuroendocrine tumor with chemoradiation because lymph nodes were involved, those were involved with neuroendocrine tumor, and then this appeared to be just a stage 1A, concurrently developing or synchronously developing squamous cell carcinoma, which we just cyber-knifed. And you know,
It
he's
has a
on
direct effect on staging,
right.
though. I mean, that's a huge.
What made you biopsy both tumors?
They had a different appearance and different SUVs on the PET scan, and even the radiologist questioned that they may be coming from different origin cells.
So I just want to throw one thing in. So important that you have a multidisciplinary team, because that's where this really popped in, and even the pathologist, you know, pathologist, pulmonologist, cardiologist, radiologist. That's why that's so important that one person picks up something that, you know, maybe isn't a specialty of the other person.
Right.
I think there's more online.
Sure.
No, I have a couple more questions. If you opt for chemotherapy, a chemo combination before targeted therapies, could you be excluded from a clinical trial?
In some clinical trials, I think you can be. I mean, every clinical trial has its own sort of independent rules and regulations. You know, some clinical trials require that not only have you had chemotherapy, but 2 or 3 lines of chemotherapy before you enroll in the trial. Other trials, depending on how they're designed, because they really want to see the effect of their novel drug or agent on treatment-naive cells, will say if you've had any treatment of any kind, you're disqualified from the trial. So it depends on the trial, but yeah, in some cases it could disqualify you. In other cases, it could be an inclusion criteria for getting into the trial.
Right. Is there a test that you would recommend for PD-1 expression?
Well, I would say that one way to get tons of information all at once is by using some of the newer molecular profiling offerings, whether it be Foundation One, the Caris Molecular Intelligence Profile, Guardant's liquid biopsies. Most of them are incorporating PD-1 expression into their analysis or basic panels, knowing that immunotherapy is becoming such an important form of treatment and really catching on.
Yeah.
So I think any of those options are reasonable.
Okay. And then just a couple compliments, because people always like compliments.
He doesn't want to hear any compliments.
I know. Everybody, no, not everyone will admit it, but everybody loves to hear a compliment. Always enjoy watching Dr. DORMADY. What an amazing man and how he treats the patient.
Oh, that's nice. I really appreciate that, but I think what I'm just trying to convey is...
a compliment.
I do. I said I really appreciate it. I really do. And
that same person wants to know if you would do a remote second opinion.
Oh, sure. Absolutely. I'd be happy to do that. But I think what I'd love to... this is such a nice forum because he really does stretch out. I mean, even around the world. I think we have patients in other countries watching this, is that... what I try to do and try to convey to patients is that just try to find a team of doctors that you believe is going to fight for you. And I mean, I really love being an oncologist. I think you meet so many people, and all this is, you realize this could be me as well, just as easily as it could have been any of the patients. You know, every story tends to start to say, oh, I just had a little pain here, you know, I had a little cough. I mean, it's any one of us. And what you realize is that I'm just a person who was able to have some training that allows me to help another person. And what you really want to find in your oncologist, in your team, is someone who's going to fight for you and is going to realize that, hey, you know, if you want to keep going, it's my job to help you keep going. Let's look for clinical trials together. Let's put novel combinations together. Let's recycle chemotherapy. Let's do some things that keep you going. And just someone who's going to be your advocate and someone who's going to look at you. And when they look at you, they're going to look at you as if you're their family member. You know, they're going to treat you the way they want their mother and brother treated. And that's the only thing I try to do when I treat patients.
Sometimes we'll be talking to a patient that says, well, my doctor said no. And we tell them, well, go back and ask their doctor if this was their wife or their child or their husband, what would their decision be? That can really change up the room a bit. Right? It's like, well.
It can, you know. I found that when I was in training at a neighboring, very close academic center that won't be named, which I have great affection for, by the way. You know, at every academic center, you'll always have a very professorial mentor there who, you know, and I asked a doctor that very question one day. I said, well, you know, I really think we should do this. And he was thinking, well, you know, I wouldn't necessarily do that. It was so obvious that that's what anybody would recommend in that situation. I said, you know, really, if that was, you know, your mom there, you wouldn't recommend that? And he said, well, I would be far too emotional in that situation to recommend anything. But
I'd
it is,
send her to somebody that would do that.
but it is true that you do notice that and I've had this situation develop, those very doctors who have argued with me for years about, well, that was too creative, that was too aggressive, and then all of a sudden, you know, their family member gets sick, and sure enough, they show up saying, Shane, you know, what do you think?
Break the rules.
Break the rules. Why aren't we ordering a PET scan here? Why aren't we doing it? And so, you know, I think Bonnie's right. When the shoe's on the other foot, and maybe it's not you. You know, it's interesting. You picture yourself as having the disease, and it's frightening. But when you love someone and you think of your wife or your child, your husband, your parent with the disease, that's when it really sinks in.
The speeding truck is coming down the hill, and you're going to stand in front of it and make sure these things happen, right? Shared decision making.
Do you have a question? Yeah, go ahead.
a couple times.
Mm-hmm.
And you were talking about the maintenance,
Mm-hmm.
which hasn't done, but I have a question, two questions. What are the side effects of that maintenance that you had suggested?
Well, that's a great question. Are you talking about oral etoposide maintenance? Now, here's my thinking, and I'm sure that if there is an academic physician watching this, they're cringing, but my reasoning behind recommending this is very simple. Listed as a standard treatment for second and third line, fourth line, when you've moved through other things for small cell lung cancer, is oral etoposide used on its own. Now, my experience with that is that the drug oral etoposide alone, generally speaking, is not that powerful. So when you're trying to control small cell lung cancer that's already progressed through multiple other lines of therapy, using that one isolated pill usually does next to nothing. Now, in rare cases, it will work even in that setting, but that's really 1 in 1,000. So my thinking was, what if you took this therapy that isn't so effective as a second and third and fourth line drug, but yet then after a patient's had a very nice initial response, taken advantage of its ability to attack neuroendocrine cells, and we're not asking it to take a tumor burden that's yay big and reduce it to this. What we're asking that oral etoposide to do is to take a tumor burden that we've already reduced and now sit on it and keep it that low for as long as possible. The argument to use maintenance therapy is one that can be argued from both positions ad nauseum. My experience with it, and again, I don't just say this as someone who says, well, this is how I like to do things. I mean, we have analyzed our clinical outcomes at my institution, and they're unsurpassed. So something in the way that we are thinking about these patients is working, okay? And that's what's leading to better outcomes. And so that's my justification for thinking that way, and sort of saying maintenance therapy does the following. It keeps the response to your initial treatment more durable. And as I said before, if the disease starts to get more active, it does so in a much less explosive fashion. You have control of the disease and can catch it before you're hospitalized or a catastrophic complication occurs.
The side effects. So
side effects, excuse me. Yeah, there was an original question there. Side effects. What side effects?
What's the length of people that have taken it when they've had to do like that second round?
Okay, very good question. So that's the other thing that's so attractive about it as a maintenance drug. It's incredibly well tolerated. Incredibly well tolerated. It's oral. You don't have to spend, an inordinate amount of time in the infusion center. You're not there every week. It's less suppressive of the blood counts, so there's not as much danger there. And so exactly, the benefit in terms of effectiveness, durability of response, and tolerability far outweighs, to me, its risk. So that's just one argument from my perspective, and I found that works really well.
Okay. And what is the thing again? How much is it again? I mean, what is the...
Well, that's a much more granular...
I wrote it down.
That's a much more granular recommendation. There are a million ways to do it. You can take the pill every day, 3 weeks out of 4, 2 weeks on and 1 week off. All kinds
like birth
of
control.
Yeah, all kinds of permutations.
Comes in a little round.
It works as birth control too, by the way.
Does it really? There you go.
We've got about 5 or 6 minutes left. Does anybody have any questions? Because one of the things I wanted to talk about, we've kind of run the gamut discussing, the different treatment options, chemotherapies, targeted therapies, immunotherapies, across the board for these diseases, when and why they're relevant. But one of the things that we didn't talk about that is near and dear to my heart, and as being part of a person's treatment plan, is the supportive care. So how are we managing the potential side effects, and how important is it to stay on top of those when going through therapy?
Oh, well, that's critically important. I mean, I think, believe it or not, Danielle, that's a good point. I think that, as we analyzed our statistics at where I practice, what we started to see was that people were not falling off their treatment schedule. And what that means is that as a collective group, our nurses, nurse practitioner, ancillary staff, nutritionist, nurse navigators, myself, we were all trying to be preemptive about side effect management, nausea management, prophylactic hydration, bringing patients into the clinic to just have their systems flushed by IV fluids. And what that leads to is a patient who will not take, if the treatment recipe calls for every 3 weeks you're having treatment, well, that patient's not doing treatment on the 4th week because they were so sick for 2 weeks, they got their treatment schedule was thrown off. I think a lot of these recipes really are predicated on the pulsing of therapy at the right interval. So symptom management keeps patients on schedule. And so you do that by having a team that understands that. You also do it by becoming pathologically accessible to your patients, giving them your email, your cell phone, and saying it's okay to call me, text me, email me, just to tell me so that we can jump on. And I say that, but I think it's a nice way to practice. Typically speaking, if a patient emails me 7 questions, I'll just, it's quick responses, and you can just triage things. You know what? That's a very detailed email. Why don't you come in for an appointment? We'll discuss all of it. Whereas when something more urgent is happening and someone's saying, well, this side effect is occurring, you can say, that's a problem. Come into the clinic, you need to be hydrated. Come into the clinic, you need this medicine for neuropathy. Come into, you know what I mean? So it's not the most onerous thing to be that accessible. You can just triage things very quickly when you have a good team, and I found that helps. Keeps patients on treatment, keeps them feeling better. It improves their quality of life as they go through treatment, because I always try to tell patients, look, I desperately want you, as you go through treatment, to get out of town, take a vacation. Yes, you've been diagnosed with cancer, you have cancer, but cancer doesn't have you. Live your life. We want your treatment to be an inconvenience. This is annoying. I have to go see Dr. Dormady again. But on the other days that you're not here, you're living your life, you're getting out, you're even going to the mall, you're just walking around, and so that's another philosophy that we try to stress, that supportive mentality where you realize keeping your mind and your heart and your body all pushing in the same direction is how you beat the disease.
Thank you for that. I mean, there's a lot of patients, quite often, they aren't going to see their docs, this has been happening, but I'm going to be in and see you 3 or 4 weeks, and you're like, no, you can't not eat for 3 or 4 weeks. So we need to let him or her know that now, right?
Right. That's exactly true. Right. And a lot of patients, some patients are so respectful, and they don't
want to bother you.
I don't want to bother you, and I just say, look, I'm way beyond that in my career. I've sort of gone past. I want you to bother me. It's okay. You're not offending me. You're not offending my family. You're not taking time away. I'm going to answer these questions anyway. Just send me a message. It takes me 2 seconds. I send it back.
But in your defense, because I think that is just so amazingly noble and so rare. I mean, that just really does not happen. So I would suggest that people know, if this is important or it can wait. So to if I'm feeling faint and I can't stand up, email, boom, go to the emergency room, do something.
Right.
So, because I just think that's amazing that you do that.
Thanks. Well, thanks, Bonnie. But most people, thank you. Most people don't. I found that a lot of doctors will say, well, I can't believe you've done that. But what I really find is that most patients don't abuse it. And it doesn't really alter my own quality of life. And it's just a little bit of extra effort that kind of tells someone, you know what, I'm still there. Like when they get an email back at 1 in the morning, they're like, oh my gosh, he wasn't kidding, he'll email me back.
It helps to keep them out of the clinic if they don't really need to be there.
Right.
You can tell them, oh no, you need to come in, or try this, email me tomorrow and tell me how it's working.
Right, there's that, and there's just the reassurance, I think, for some patients that, oh wow, I got an email back. He's actually listening, and he's there. So, and then that relieves a lot of fear, such that you don't have to, you don't become quite as
Right.
alarmed by every little tweak and symptom
Right.
that occurs. So
Right.
yeah.
Yeah. Good stuff.
Does
Really good
anybody else
stuff.
have any questions? Anything online? Nothing? Nobody? Not one person? Okay.
I would still be someone who, if they hadn't coughed up that tiny bit of blood, would never have been considered for a biopsy for lung cancer. I've never smoked, pretty healthy.
Right.
I had just a little bit of a cough, but yeah, it's fine. You know.
Give you some antibiotics.
Are they doing anything? Where are you seeing that going for the future? As it seems that there are more women with this sort of cancer.
Maybe like early detection?
I think we have to get that into the general practitioner. The first place you go needs to be alerted. Coughing up blood, that's never normal.
Yeah.
You know, that's not okay.
Yeah, well, Bonnie's right. You know, I am amazed sometimes as an oncologist because I think in a patient where they haven't smoked, and it's amazing to see how long it will take some doctors to even order a chest X-ray.
Right.
Where I've seen patients come in after 9 months of coughing and being
Right.
treated with acid reflux medications and 8 courses of antibiotics. You know, finally someone says, well, you know, why don't we get a chest X-ray?
Right.
And
I was at the doctor between my calling in to the nurse within 12 hours, and she shot me off a series of tests. But it was such a rare occasion that I coughed up this little tiny thing. And I'm just wondering if in general, if there's I've done colonoscopies, I've done mammograms. I'm wondering if there's going to be
so
any.
getting back to your question, yes. So I think there are a lot of genetic assays that are being developed, trying to not necessarily devise treatment strategies, but stratify risk in patients before they develop cancer. You know, probably the best examples of this are in breast cancer, but there are even using breast cancer as an example, you know, just a few years ago, we tested for the BRCA1 and BRCA2 genes, looking for, you know, inherited risk sort of factors. But now that panel of genes that we look at in breast cancer is, you know, 15 genes wide. So the point being, I think, yes, there's a lot of investigation, especially in patients where you don't have the classic environmental risk factors. You know, why did you develop the disease? Absolutely. We don't have the answer yet, but that is being explored.
So I want to say, everybody on Ustream and everybody in the room, you can hang tight for a couple of announcements. I want to say thank you to everybody for being in the room, to Dr. DORMADY for coming down, everybody online, and to everybody who's watching local cable TV. We appreciate you coming back and seeing what we're doing. So thank you all.